Hello, everyone. Welcome to TMA's Ask the Doc webinar series. My name is Rachel Bromley, and I am TMA's Senior Manager of Support, Education, and Advocacy. And tonight we are proud to host Dr. Cheilonda Johnson and Dr. Robert Hallowell. Unfortunately, Dr. Danoff is unable to be here this evening. She was detained and regretfully cannot be with us, but we still have two pulmonologists on deck to answer all your questions. So we will still have a great time tonight. So I just wanted to say Dr. Cheilonda Johnson is an assistant professor in the Division of Pulmonary Allergy and Critical Care and member of the Interstitial Lung Disease and Sarcoidosis Program at the University of Pennsylvania. Dr. Johnson is an expert translational researcher of interstitial lung disease associated with autoimmunity. She is committed to reducing the significant morbidity and mortality associated with autoimmune ILD. Broadly, her research focuses on the clinical and genetic determinants of autoimmune ILD and health disparities in patients with ILD. Dr. Robert Hallowell is a pulmonary and critical care physician at the Massachusetts General Hospital, where he is the director of the Interstitial Lung Disease Program and the Pulmonary Ambulatory Clinic. His research focuses on factors that influence outcomes in patients with various types of interstitial lung disease, particularly those associated with autoantibodies and rheumatologic disorders. Thank you both for being here.
Thank you for having me.
All right, let me spotlight both of you. All right, it's so good to see you. Well, if you have a question for one of the doctors, please put it in the Q&A and we will get to as many of the questions as we can today. So let's go ahead and get started. And again, either one of you or both can answer, it's up to you, but what is ILD and can it be prevented? If so, how?
I can start. And so
Okay.
I think I can answer this question in a way too that may answer many of the questions that came up in the pre-submitted questions. And so interstitial lung disease is an umbrella term for a bunch of different disorders that can affect the lung in similar ways. And generally that's a combination of inflammation and or fibrosis or scarring of the lung. And so interstitial lung disease is not just one thing, it's actually about 200 plus different things that can all cause that, which frequently is a source of confusion. And so one of the questions that we received was, what's the difference between interstitial lung disease and pulmonary fibrosis? And so pulmonary fibrosis quite simply just means scarring of the lungs. And so you can have pulmonary fibrosis from anything that caused prior injury to the lung. But when we're talking about it in the context of interstitial lung disease, we're talking about people who have scarring as the result of either a condition of known cause or unknown cause. And generally, these are progressive disorders that will continue to worsen without intervention. The question about prevention is a somewhat loaded one, but a great question. It really depends on what we think the underlying cause is. And so there are some types of interstitial lung disease that have known cause, and there are some that have an unknown cause. And so unfortunately, if many of those diseases have unknown cause, we really don't have a good way of preventing this from happening, and partially because we don't completely understand why they happen. And people who have ILD due to a known cause, again, it can be difficult to prevent completely, but we can identify patients who are at high risk and make sure that we screen for those patients, identify them early, and intervene early before the disease gets very severe. And so currently we don't have very good methods for preventing ILD, again, because we don't completely understand when and why some people develop it. And so we may not recognize that someone has ILD until years after whatever the initial insult was. But this is one of the things that we're trying to identify. And I don't know, Dr. Hallowell, if you wanted to add anything to that.
No, I think that's a wonderful introduction to an incredibly complex field. And I think part of the issue is that the field has become increasingly more complex as we've learned more and more about it over time. And a little bit is part of the problem is that the more we learn, the more we recognize how little we know about it and about the causes. and as Dr. Johnson alluded to, it can be very hard to pinpoint causes or risk factors for conditions, especially if the cause is maybe having an impact years or decades down the road. And I think what complicates this even further and makes this confusing, not only for patients, but for providers, whether they're pulmonologists or radiologists, is that all the different flavors of ILD that Dr. Johnson mentioned, the 200 plus, have a combination of elements. Some are inflammatory, meaning they're, it's inflammation of the lung. It's part of the immune system response. When you cut yourself and it's red and swollen and itchy, that component can be in the lungs. Part of it is scarring or fibrosis, as we call it, and when we're talking about the lungs. And, when your skin doesn't heal well and you get scar tissue, that doesn't ever go back to normal. And so there's those spectrums. They're both technically interstitial lung disease. And then you can have a combination of the two. And sometimes the inflammation causes scar tissue if it doesn't heal appropriately or if it's not treated over time. Some conditions like idiopathic pulmonary fibrosis cause scar tissue for reasons we don't understand. And then you throw into the mix conditions like myositis and other autoimmune conditions that are associated with interstitial lung disease. And so very quickly, it gets incredibly complex and confusing, and there's no one size fits all description of this disease. It's kind of like people who own dogs, right? There's many different types or breeds, even though it's the same species, right? And they all have different temperaments, personalities, and those temperaments and personalities can change with time depending on the mood. And so it is very confusing sometimes, even for providers, to have a grasp of exactly what flavor we're dealing with.
Well, thank you so much. And I got so excited that I jumped straight into the Q&A and I forgot to have you guys talk about your work. So Dr. Johnson, do you want to take a few minutes to talk about your work?
Sure, I can be brief. I think probably because the audience might want to hear the answer to more of their questions. So I think it's okay that we skip right in, but I can just say briefly that as the introduction stated, I do research in patients who have ILD associated with autoimmune conditions, and I have a focus on myositis, which is part of the reason why I'm speaking with you all today. And so one of my big current research projects that's done in association with the Myositis Association is looking at patients who have myositis with and without ILD, trying to understand if there are genetic risk factors that differ between the two groups. And also looking at the lung tissue of patients who have myositis ILD who've gone for lung transplant and trying to understand if there are certain features of that lung tissue that could give us some insight potentially into some of the things that are happening in the lungs of patients with myositis. And so I'm currently enrolling patients into my study for the first portion, the genetic portion of my study. And we're currently at about 78% enrollment. And so we're doing very well. And so my goal is in the next 6 to 9 months to be able to start analyzing and disseminating that data so that I can share the results, and hopefully we'll have some great insights.
Well, I just wanted to say that I think the biography gave a little bit of alarm because of the word morbidity, significant morbidity. So I got a question from someone that said their rheumatologist has not mentioned anything about morbidity. Can you talk a little bit about that concern?
Yeah, and so we know that if you take all comers who have an autoimmune condition, the presence of ILD significantly increases the likelihood that that person will die over the next 5 years. Now, that doesn't mean that this is a universal phenomenon, but this tends to be, ILD tends to be one of the leading sources of death or disability in patients who have autoimmune conditions where ILD is heavily associated. And so we know it's very important to identify and recognize patients who have ILD, again, because generally this is going to be one of the more significant manifestations of the disease. And so, again, this is not a universal thing, but it's an important part of the disease to recognize and treat early.
Thank you very much. Okay, Dr. Hallowell, would you like to take a few minutes to talk about your work?
Yeah, sure. And I'll add here that Dr. Johnson is being humble. The work that she does is incredibly cutting edge, and there are only a handful of people around the world who do the kind of cutting edge translational research that she does in this field. The work I do is of a similar vein. I do mostly retrospective and cohort work in patients, looking through charts, making associations between patients and different antibody presence with outcomes, looking for patterns in disease to have a better understanding of why patients with autoimmune conditions, also a focus in myositis patients and myositis groups, why they have the outcomes they do, why they develop the patterns of diseases they do, looking for better forms of treatment. And I'm also involved in several clinical trials, both industry and non-industry funded. The the harder, more difficult translational research, the kind of stuff that people like Dr. Johnson does, I do in collaboration with some of my colleagues here. And so I just wanted to say that about Dr. Johnson's work, because it really is phenomenal, and she wouldn't say it herself, so I'm going to say it for her.
Okay, well, go ahead.
No, I just, the point about the morbidity and the words morbidity and mortality, I think that you brought up, though, Rachel, in terms of ILD and patients with myositis, because I think this is, it's kind of an elephant in the room for a lot of our patients when they come in. And I think it's something that people think about, even if they don't want to talk about it. And, you know, I think Dr. Johnson made a good point that, you know, just because you have ILD, you know, it doesn't mean that you're going to die of your disease. It doesn't mean that you're going to have necessarily the bad outcome. But I think the point is that when you have any autoimmune condition, any rheumatology condition, myositis or rheumatoid arthritis, et cetera, those patients, if they're going to get really sick, it's not because of their joint pains or their rashes, et cetera. It's if the lungs get involved, the lungs are a more vital organ than the joints or the skin. And so we have to take the lung disease seriously, and it tends to get more attention because it can cause problems. Breathing is important. And because of that, the medications, the therapies we choose end up having to target the lungs, and we have to treat the lungs rather aggressively with different medications that have side effects, et cetera. And so I think because of that, you see the fact that we talk about higher chances of getting critically ill or having a morbidity in patients who have involvement of the lungs versus other parts of the body, simply because of what the lungs do for us.
One of our questions is, you know, how do you treat ILD, and does ILD heal? But as you're saying, there can be 200 different types of ILD. And so that may be a question of how many types of treatment are there for that many presenting diseases.
Well, I think Dr. Hallowell kind of alluded to this earlier in terms of us thinking really simplistically about ILD as being either primarily inflammatory, fibrotic, or scarring, or both. And so as a general rule of thumb, inflammatory injuries can sometimes be reversible, whereas fibrotic or scarring of the lung, just like a scar anywhere else on the body, is not reversible. And so when someone has an inflammatory condition, which myositis is, you want to try to intervene at the stage where you think you have reversible disease before you get to the point of scarring, because that injury will not be reversible. And so certainly people who have ILD can have improvement in their lung function, improvement in the appearance of their chest CT scan with treatment. But like anything else, if it's recognized too late, it may be past the point of reversibility. And so at that point, the goal of treatment really is to prevent any additional injury to the lung and further scarring of the lung. And so the short answer is that it depends. But certainly we can see people have very favorable responses to therapy and significant improvement in their lung function with treatment, depending on the stage at which their disease is identified.
Thank you so much. That's a very positive answer, and we appreciate some optimism. So, okay, our next question then is, at what point should people seek out the care of a pulmonologist? Oh, you're smiling at me. It's your turn, Dr. Hallowell.
Well, I think you have a biased panel here. I won't speak for Dr. Johnson, but my personal bias is that if you have an autoimmune condition, if you have myositis and you're found to have lung involvement, you should have a friendly pulmonologist on board early, as soon as possible. You may only have mild disease. You may have stable disease. But I think you need some degree of monitoring. And I think even if your initial visits are infrequent, once or twice a year, you should have us on board. You should have a baseline of testing, breathing tests, et cetera, so that we can follow you. And so that if things start to change, we can catch that early and intervene as soon as possible. Because there are some therapies that slow progression of disease, even if they don't reverse it, and sometimes having an early intervention is important.
What does lung involvement look like? I mean, how does that present? Is it just shortness of breath or difficulty breathing? Is it tightness in the chest? What does it look like?
Yeah, so for different patients, that's different. Different patients have different symptoms. And it could be a cough. It could be feeling more winded when doing normal activities that you used to be able to do more easily. It could be a lower oxygen level noticed at your primary care visit. It could be a sensation of chest restriction. So it depends on the patient.
Okay.
Yeah, and I would just add on to that comment that, this is a big source of debate in the field. And I think that part of the reason, outside of people with myositis, in general, people who have conditions where they're at high risk for developing ILD is, when and how should we screen patients? And you have to balance the benefit of identifying early disease with the potential harm of causing people a lot of distress when they have some mild lung involvement that may never progress or cause them any problems. And also the expense of doing a lot of testing that ultimately might not show any significant findings. That being said, I do think that we do know a lot more about specific forms of myositis, particularly with the use of myositis antibodies, people who fall into higher risk groups for having ILD versus not. And I think that someone who falls into a higher risk group really would benefit from having an early visit with a lung doctor, even if they're not experiencing any symptoms of lung disease yet. Again, because they're just at such high risk that I think having that initial assessment is really important. And it's always better to have the doctor say, nope, everything looks good, I'll see you in a year, versus trying to come when things are too late and put the cat back in the bag. And so I think the answer really is going to vary depending on everyone's specific underlying condition. In terms of when is the best time to see a lung specialist.
Okay, and let's say that you've figured out that it's time, and what is the testing like?
So generally, we start out by doing a combination of pulmonary function test or breathing tests. So we have you sit down and you blow into a device. We have you sit in a box. We measure actually all of the gas in your lungs. And we see how well you transfer gas, so how well you get oxygen from your lungs to your bloodstream. And this can be very helpful in terms of just letting us know, is there any abnormality at all with the lung function? And if there is, what's the degree of the abnormality? And then we're going to be doing chest imaging. And usually our preference is to do something called a chest CT scan. But some patients may start out with just getting a plain X-ray. But generally, that's going to be the place that we start as lung doctors, is getting pictures of the lung and seeing how well the lung is functioning. And then in the visit itself is really going to involve mostly just us asking a lot of questions. and then taking a listen to your lungs and looking also at your whole exam in terms of how active your myositis is in general, which can give us some kind of insight into your overall disease activity. And so a pretty comprehensive examination in the clinic as well, along with the testing I already mentioned. And typically we're going to be doing those breathing tests that I mentioned with each of our subsequent visits down the road.
Okay. And Dr. Hallowell, if you could answer the question about common medications used to treat ILD.
Yeah, so I think this is going to vary on what we think the pattern of interstitial lung disease is. In patients who have underlying myositis, the standard approach initially is going to be to use medications focused on addressing underlying inflammation in the lung and an underlying autoimmune component, or a component where the body's own immune system is getting confused and trying to attack the lung tissue because it is seeing the lung tissue as foreign or different. And so most patients with myositis or an underlying autoimmune condition will have some degree of exposure to prednisone or steroids or other medications that suppress the immune system. These are medications like mycophenolate or azathioprine or rituximab, just to name a few, that work by turning down the volume on the immune system or reducing the strength of the body's immune system. The goal is not to turn the immune system off, because obviously you need a functioning immune system to stay healthy, but to just turn the volume down a little bit so it's not as active in the lungs or overly active in the lungs and causing a problem, causing damage. And so in general, that's the approach in patients who have ILD related to myositis. Now, there's also a subset of patients, though, who either because treating the inflammation is not effective, or because they have a lot of scar tissue, or there's patients who don't have inflammation or an autoimmune component who have purely scar tissue in their lungs, where we're using an entirely different class of medications that are called antifibrotic medications. And these are medicines that don't touch the immune system at all. They don't work on inflammation at all for the most part. And their objective is to slow the progression of scar tissue, to stop the body from depositing scar tissue in the lung inappropriately for reasons that we don't necessarily understand. And so these medicines don't reverse anything. They don't fix anything. As Dr. Johnson had mentioned, scar tissue, once you have it, it doesn't go away, whether it's in your lungs or on your face or on your wrist. But these medications try to slow that process. And so that's sort of those are the two different types of medications we use, and they kind of line up with those two generalized groupings of interstitial lung disease that exist. There's inflammation, there's scar tissue, and then there's a lot of overlap in between. And we have patients who sometimes are on both types of medications in certain instances where the doctor feels that it's maybe appropriate to try both. But now we're getting into sort of specific examples.
I've got a specific question in here asking about NAC. They've read that it's been helpful and mucolytic for patients with COPD, and they want to know if there's any benefit to taking NAC for interstitial lung disease to decrease airway obstruction.
Yeah, so we've looked at N-acetylcysteine specifically in patients who have idiopathic pulmonary fibrosis. This hasn't been studied in patients who have myositis, ILD, I should mention. It really is a medication that offers no harm, but the studies seem to suggest that it doesn't actually provide much benefit. And so, again, this is data from patients who don't have myositis, patients that have idiopathic pulmonary fibrosis, but we tend to kind of extrapolate the control data we have from one group to another. And so at least at the moment, there doesn't appear to be a strong benefit of using it. But again, if someone was on it, I wouldn't twist their arm to come off of it, because I don't think that is causing them any harm, but again, probably unlikely to be helpful.
Okay. I have a question about someone that would like to do something. They want improvement without using steroids or other medications. They're saying that, each person is born with a certain amount of lung capacity. Are there any lung exercises that I can do daily that would help my lungs expand more and help me to breathe easier without the use of medications?
I think there are certainly exercises. So there's two different, I think, camps of exercises. There are exercises that are geared towards the lungs themselves, breathing exercises, and then there's general exercise aimed at improving strength in the rest of the body, the legs, the arms, the kind of stuff that we see with pulmonary rehab, focusing on generalized conditioning. And I think there may be benefit to both of those. Although neither actually change the physiology and what's happening within the lung tissue itself. And so I think these are important distinctions to make, and worthy of discussion. So, I think lung exercises, breathing techniques, I think can be very helpful in allowing patients to sort of reteach their body how to slow breathing, how to focus on breathing, and how to become in tuned with the breath and what it feels like to breathe under new circumstances. And this is starting to get into the realm of sort of mind-body awareness. When we're born with healthy lungs and we spend most of our lives breathing in a healthy way, our brain interprets healthy breathing a certain way and is accustomed to a normal breathing pattern with normal, non-inflamed, non-scarred lungs, and has a sort of baseline acceptance of what that should be. We feel short of breath when some of these parameters become abnormal or thrown, sort of helter-skelter. When patients have chronic lung disease, even if we can't fix what's happening in the lungs, it can be helpful sometimes for patients either through breathing techniques or meditative breathing, et cetera, to try to retrain the brain to at least partially accept that this new reality is somewhat normal for them and that they're safe, they're not dying in the moment, that their oxygen levels are okay, even though they don't feel that the breath they're getting is normal. And there are forms of cognitive-based therapy that people have started looking at in patients with lung disease. People have started looking at Tai Chi and different breathing, et cetera, in patients who have chronic lung disease. And for some people who are willing to try this can be successful. And so to that end, I think certain breathing techniques actually can be quite beneficial if patients are willing to put in the time.
Are any of them preventative if they don't have signs of ILD?
They are not. And because the problem is that is focusing on symptom management and the body's interpretation of a symptom. It's sort of like the check engine light in your car, right? If something's not normal with how the engine's functioning, the computer system is going to interpret that and put on a check engine light and send a warning. You can reconfigure the computer to not send that light anymore and to stop beeping at you. But it doesn't change the fact that something in the engine may still not be correct. So it's sort of retraining the brain and the body to say, reinterpret this and deal with this. It's sort of like, Maya Angelou, my favorite poet, said, if you can't change the situation, change the attitude towards it. And it's like changing the brain's way of reacting to a condition in the lungs. And so it's not a perfect solution, but it at least helps change the level of shortness of breath incrementally and reduce the amount of panic that patients can feel when they're incredibly short of breath. Because a lot of our patients get very anxious, very panicked when they can't breathe. And that
just all this talk about breathing is making it hard for me to breathe. And we're
right. And it's a natural response. And on the other side, the strengthening of leg muscles and arm muscles and doing exercises and pulmonary rehab makes the body stronger so that you're less reliant on your lungs. right? So if your arms are stronger and your legs are stronger, it's less taxing to lift a laundry basket or a grocery bag. So you're not going to get as out of breath or winded doing that activity. But that doesn't change what's actually happening inside the lungs. So none of these exercises are going to prevent scar tissue from getting worse, reduce inflammation in the lungs, and it's not going to change the way your breathing tests look when you come to see the doctor, because those tests are designed to measure the actual physiology of the lungs, the gas exchange of the lungs. And so your oxygen levels at rest probably aren't going to change. Your CAT scan's not going to improve. So it's really just giving you better gas mileage for what you already have. It may certainly improve your quality of life, which is critical, but it won't stop the actual process that's going on organically. And that's where the medications come in. If that
Thank
makes
you.
sense.
And if
Mhm.
I can just comment on that, because I think that kind of reading in between the lines of that person's question, I think this is something that comes up frequently. And it's a challenge just based on the current tools that we have available to treat people who have these types of conditions, which is that none of them are ideal. And they all come with a host of side effects. And I think patients are frequently looking for a way to manage their conditions without the potential toxicities of the medications that we have to offer. And certainly, I wish that I could say, yeah, if you cut XYZ out of your diet, or if you walk more or do breathing exercises, you wouldn't need these medications, but we're just not there. And so I think that we recognize that people want solutions that don't involve toxic medications, but we currently just don't have any better solution for it. And so I think that, as Dr. Hallowell said, the exercises are important, but it's a complement to the medication therapy that you're getting. It can't replace it.
Thank you. We've got a question about are all myositis types susceptible to ILD?
Yeah, so that's a great question. I think that was kind of what I was speaking about earlier in terms of screening patients for ILD and referring patients with myositis to see a lung professional. So we know that not all subtypes have the same risk. And so, for example, people who have inclusion body myositis, developing ILD is extremely uncommon and quite rare. It's actually case reportable. And then among people who have known myositis specific antibodies, so these are antibodies that we can see in the blood of people who have myositis, that people who have certain types of antibodies, the presence of ILD is also uncommon. And so this can be helpful in terms of risk stratifying patient, meaning in terms of how early you're likely to send them to see a lung doctor. But again, there's no type of myositis where you never see ILD. And so I think that if someone has respiratory symptoms, we should always take it seriously and fully investigate it. But certainly the risk is higher in some groups than others. And so the highest risk groups for ILD that we see are patients who have anti-synthetase syndrome and patients who have MDA5 positive antibodies. Those are going to be the most common groups that we see. And then among people who have diagnoses, but they don't have an autoantibody present, which can happen about 30% of the time, we see it most commonly in patients who have dermatomyositis. And again, not so commonly in people who have necrotizing myopathies or people who have inclusion body myositis.
We have someone in the audience whose family members, several family members have had pulmonary fibrosis, and they want to know if it's hereditary. Your turn, Dr. Hallowell.
Sure. We now know there are certainly many instances where interstitial lung disease, pulmonary fibrosis variants can run in families. And so it can cluster in certain families. The incidence can be much higher. And in some of those cases, we have been able to identify specific gene mutations that run through the family that are hereditary, that are passed down. And these genes are associated with an increased risk of developing interstitial lung disease. So there are blood tests that can be performed to look for some of these genes. There are also some families where there is clustering of interstitial lung disease cases, and there definitely seems to be a very strong hereditary component, and we don't identify a gene on testing. And that may be because there are genes that exist we just haven't discovered yet. And people doing work like Dr. Johnson will discover the next gene in next year or the year after, doing translational research. So just because we haven't found it doesn't mean it's not there, because new ones are being found with increasing frequency. So for those families, there are centers that have expertise in genetic screening and genetic counseling, and so there, to previous discussion about the frequency of screening and how often to look at patients, or look for interstitial lung disease in patients who currently don't have disease or don't have symptoms. This is also a hotly debated topic in the field. When to start screening patients who have a strong family history for interstitial lung disease, at what age, how do you screen them? Do you get a CAT scan or not? Do you just get breathing tests? At what age do you do that? Do you just do genetic testing, et cetera? But certainly if there are many members in a family who have interstitial lung disease, it certainly could be a familial form. And there is at least, could be useful testing to identify that, and identify, members of the family who are at greater risk or less risk within the family. Dr. Johnson, is this maybe something I don't know if you have anything to add to that?
No, I think that was a great answer. And I guess the point is that I would kind of just reiterate, it's just the uncertainty around what to do with this information. And so I should just be clear that, there hasn't been a clear gene identified that we see tracing heritability in myositis ILD. Most of the things that we're talking about are in patients who have idiopathic pulmonary fibrosis.
Right.
And then even among family members, even if you identify someone who may carry that variant, their actual risk to go on to develop disease may vary. And sometimes this information just offers more distress because, as Dr. Hallowell said, we really don't know what the appropriate intervention is and at what time. And so oftentimes all we do is end up just monitoring these people more closely. But ultimately, we don't have a current intervention to offer someone at the time of testing that we know will prevent disease. And so it's kind of like identifying something that may or may not be a problem for you. So again, it's that potential to introduce distress. But this is a very important question, and obviously part of something that we're trying to understand is just how does heritability affect your risk, and how can we identify these factors early?
I speak on behalf of many of the patients when I say that we really appreciate your attention to mental health as you are talking about introducing stress to the patient and keeping, realistic purview of things. So thank you for that. We've got a question about, okay, let's say you have dermatomyositis and you have not developed lung disease within a year of diagnosis. Are you in the clear, apparently, is what they would like to know, or can they still develop it?
Yeah, so that's an excellent question. We tend to see that people will develop their symptoms and evidence of ILD pretty close to when they develop their extrapulmonary symptoms. And so I think the longer you go from the time of your diagnosis with, for example, we're saying dermatomyositis here, and not having any evidence of lung involvement, the less likely it is that you're going to develop significant lung involvement over time. A year is kind of an arbitrary number. I don't think we know enough about the complete natural history of everyone to say that that's the exact time point. But again, the more time that goes out from your diagnosis, the less likely it is that that's going to become a significant problem for you. And so I do think that with time, you can breathe a little bit easier, that you likely are not going to have this be a significant phenomenon.
Someone says that they have anti-PL7, but not ILD yet. Would starting on an immunosuppressant that is specific for ILD be prudent, or would methotrexate be just as good? Are there any contraindications to starting on something other than methotrexate?
So, at this point, we don't have any evidence that using medications ahead of time prevents the development of interstitial lung disease. And so, all these immune suppressing medications all have side effects. They have risks of infection, other toxicities, a questionable risk of increased risk of possible skin cancers or lymphomas, although that's now being debated in the myositis community or rheumatologic community, but they're not benign medications. And so I think they should only be used if necessary in patients who have established interstitial lung disease as active therapy, because we don't think or know that they're going to prevent the development of ILD. It sounds from the question that there is discussion of using something like methotrexate, maybe for a non-pulmonary reason. And so I think if there's not lung disease and there's a discussion of having to use something like methotrexate or another agent to control joint symptoms or skin symptoms or something outside the lung, I think we often think about the agent that's being used and whether or not it has potential toxicity to the lung or a risk of causing inflammation to the lung. Historically, methotrexate was thought to potentially be toxic to the lung from a lot of previous studies in patients with rheumatoid arthritis. In general, it's now thought to be relatively safe for the lungs. So if it's thought to be necessary to treat the joints or thought to be the best agent for another reason, it can be used. As pulmonologists, we try to use other agents if possible. I think the risk of true lung injury from methotrexate in patients with myositis is probably in the order of 2 to 3%, I believe. And I think that was a study actually done at Johns Hopkins in myositis patients by Dr. Danoff. And I don't know if Dr. Johnson was on that paper. Potentially, it was maybe right before you were there. I always think every study at Hopkins has Dr. Johnson on it. But that was actually a study that Dr. Danoff did, who's one of our colleagues there. And so the risk is low with methotrexate and it can be used.
Someone is taking Imuran, if I'm saying that right, and I don't think we've talked about that. Their rheumatologist thought this would be better with ILD. Of course, we don't have any other information than that. What's your opinion on Imuran?
Yeah, so Imuran, the generic name is azathioprine, which is one of the medications that Dr. Hallowell had mentioned earlier in the talk. So certainly we do use azathioprine as one of the potential agents to treat. Part of the difficulty with most forms of autoimmune ILD, with the exception of scleroderma, which has been the one autoimmune ILD that's had some randomized controlled trials, a lot of the evidence that we use to support the use of any particular agent is really based on not the best quality data. And there really are no studies that examine any choice of medication head to head. And so there's lots of factors that would determine which of the typical agents that we use to start, what would be the best drug for any individual patient. And so depending on that particular patient's circumstance, that might be the best initial choice of agent for them. And so it is a drug that we use commonly. And again, it might be the most appropriate choice for this particular patient based on their entire medical picture, the other medications that they take. And so again, it sounds like a reasonable choice, but that would all I'd be able to say without knowing more about the particular patient's background.
Thank you.
Mm-hmm.
This person would like help explaining pulmonary hypertension to their family and friends. They can explain ILD, but it's harder for them to explain pulmonary hypertension.
Well, they're not alone. It's difficult for us to explain it to med students and residents and fellows, and so it's a difficult concept. So I'll do my best to break it down a little bit. So pulmonary hypertension, we'll start with the name, right? So pulmonary is just lungs, and hypertension is high blood pressure. So it's high blood pressure in the lungs. And so when we go to the doctor, they measure our blood pressure with a cuff. They put a cuff on the arm, they pump it up, and it measures the pressure of the fluid that courses through our arteries when the heart pumps and then relaxes. So that's those two numbers we get. And so normally we have a blood pressure on average of 120/80. Right? So the top number is when the heart's squeezing, the bottom number is when the heart's relaxing, and that is the pressure in the blood vessels in millimeters of mercury, right? Because all the blood is under pressure in our vessels. And so that's the pressure that the left side of the heart is generating and seeing, and the pressure that the normal blood vessels in most of our body is seeing. The lungs are a little bit different. So the blood vessels in the lungs are a lower pressure system. And so the right side of the heart, which pumps blood into the lungs so that the lungs can, the blood can pick up oxygen, that's a lower pressure system. And the right side of the heart is actually quite weak and flimsy. It's a weak muscle. And so the pressure in the lungs is usually something on the order of, 20/5 or 20/10. And so it's a much lower blood pressure. Now, we don't have a little blood pressure cuff that we put around the lungs and pump up. And so the way that we measure the blood pressure in the lungs is usually an estimation when we do an echocardiogram. So when you have an ultrasound of the heart, they use the Doppler effect, so the same one that we use to see rain coming, and we look at different colors and flow curves, the same way they look for tornadoes and whatnot. They use the Doppler effect to estimate the blood flow velocity in the right side of the heart. We use a fancy equation, and we can extrapolate what the pressure in the right side of the heart must be to generate that flow velocity into the lungs. And that gives us an idea of what the pressure in the lungs must be in those blood vessels. And so it should be low. And pulmonary hypertension, as the name implies, is a condition where that pressure gets elevated. And that becomes a problem because if the pressure is elevated, the right side of the heart, which is usually weak, like me, right? I don't lift weights at the gym. So if all of a sudden you give me 100-pound barbells, I'm not going to be able to lift those. And the right side of the heart can't lift against that high pressure, and it can fail. So it can be harder for the right side of the heart to pump against that high pressure. And it can cause people to feel short of breath because that high pressure is usually caused by constriction of the blood vessels in the heart or inflammation around the blood vessels of the heart. And the reason that happens is because all that blood from the right side of the heart has to go somewhere, right? And so if you have the same volume of blood, 5 liters a minute going through the lungs through a certain number of blood vessels, and all of a sudden you start squeezing those blood vessels more narrowly, or they get thicker, or they're less compliant, the same volume of blood has to go through, but now it has to go through under a higher pressure and a higher velocity in order to get through in time. And so the pressures go up. And so that's what pulmonary hypertension is. And it can be associated with interstitial lung disease because the same inflammation that gets into the lungs, the same scarring that you can see on the CAT scan in the lung tissue can also affect the blood vessels and damage the blood vessels. And so that's hopefully somewhat explained what the phenomenon is.
I thought that was an excellent explanation.
Previously,
It wasn't brief by any means, but it was thorough and very excellent. But I would say to the person who's listening and wanting to explain to their family and friends that we will be posting this video on our YouTube channel and just make them watch it. So That's the quickest way to get the information out. So,
There's probably a
okay.
YouTube video that's a lot more eloquent and articulate than
Right, or maybe with
maybe
a
it has like some
cartoon.
cartoons or something, like it sketches it
Yeah.
out.
I'm sure there is. Yeah, a TikTok. Well, Dr. Johnson and I will make a TikTok video of blood flow, blood flow through the lungs for you. Yeah.
Okay, well, let's talk about lung transplants. Okay, if your disease is in remission, but your ILD is progressing, what is the normal cutoff age for a lung transplant? I'm currently 62, and I'm worried I may need one in 10 years from now, but will not be afforded that opportunity due to my age. And I know that's a very personal question, but I think more than one person probably thinks about these things when their lungs aren't working right.
Yeah, so it's a good question. There's lots of variability between different transplant centers in terms of their criteria for transplant. I can say that in general, it's somewhere between the age of 70 and 75 that most centers are cutting off. Here at our center at Penn, we allow people up until their 75th birthday. But that usually is someone who is otherwise very healthy, meaning that they don't have any other significant organ problems for them to go at that late of an age. And so it really can vary. I think the bigger question, though, is if someone is within the age range to think about a transplant and they haven't been referred yet, why is that if their disease is progressing? And so that person may potentially be someone who could initially have an evaluation now and at least go through the process of the evaluation, even if they're not yet a candidate, so that they can be tied in with the transplant team. But again, there's no firm age cutoff. It'll vary depending on centers, and it's going to vary depending on other comorbidities that that patient may have that make them higher or lower risk for proceeding with a very obviously serious surgery. So there's no one answer, I'm sorry.
That's okay. We appreciate the answer you gave. Okay, I'm just looking through here. Has low-dose naltrexone been used to treat ILD caused by myositis, such as antisynthetase syndrome?
Not with any convincing data that I'm aware of, unless Dr. Johnson is aware of anything.
No, I'm not aware of anything that would support that either.
We did get a thank you and best explanation of pulmonary hypertension from the crowd. So good job. Good job.
They have to say that because I'm sitting right here.
What numbers are good for the pulmonary function tests?
That's another loaded question. It depends. So, the way that we interpret lung function tests is we have a range of what we consider to be normal. So there's a lower limit of normal and there's an upper limit of normal. And so if you fall in between that range, you're considered to have normal lung function. And then depending on how far below that range you fall, you could be considered to have mild, moderate, or severe impairment to your lung function. And so we do have a lot of redundancy in our lung tissue. So you can lose a certain amount of lung function and still be able to do many of the things that you would want to do in your day-to-day life without a lot of difficulty. And so for me, I always tell the patient to focus on their day-to-day quality of life, the things they can do within their regular life, and then the trend of their lung function, then the absolute number. So patients will come in and say, oh, I failed my PFT. I'm not quite sure what that means, because I think that if someone is able to function normally, they're having minimal symptoms, and their lung function is stable, even if it doesn't fall into the quote unquote normal range, to me, that's still good lung function. And so again, it's another one of those answers where I would say it depends. But and so, lung function depends on your age, your height. And so it's going to be very variable depending on the individual patient. And so that range of normal varies depending on those factors. So there's no one number.
Okay. Dr. Johnson, we had a couple questions about your study. How might one get into the study? Are you still accepting enrollees?
We are. So, this is we consider it an observational study. It's not an interventional study. And so currently we're targeting patients who come in through one of our clinics. So either my clinic in pulmonary or my colleagues' clinics in the dermatology or rheumatology clinic. And so that's currently how we're enrolling patients, people who are already getting clinical care at our facility through one of those 3 clinics.
And a follow-up question was, at what time point do you consider a myositis patient in your study to not have ILD? How long after initial diagnosis? Isn't it possible for a patient to develop myositis later in their disease course?
So technically that can happen. We think that there are people where the interstitial lung disease can be the initial presentation. I can say that happens more commonly in other forms of autoimmunity. I mean, I think that in patients who have autoimmune myositis with ILD, that you're usually going to see those symptoms happen pretty either concurrently or in pretty close timing to each other. And so for someone to have predominantly ILD, it's unlikely that 2 years down the road, they're going to start to develop, active muscle weakness or new joint symptoms. That can happen, but again, that's not the norm. And so generally, it may be that a patient has shortness of breath, they go through an evaluation, and then it becomes apparent, 3 months later that they have a rash and some joint symptoms, but it's not going to be 3 years later that happens. That's not common.
Okay, well, what about late stage disease? Because I've got somebody who has IBM, and I know it's just anecdotal, but a friend of theirs had respiratory issues, late stage IBM, and they're just wondering if you see that often, but you're not treating IBM patients, correct?
No, I actually have 0 patients with IBM in my clinic, and I think that that's not a coincidence. And so I do think that people who have IBM could develop legitimate respiratory issues that may not be necessarily due to ILD, particularly in the context of having muscle weakness or diaphragmatic weakness. And so, without knowing the details of this person's presentation, again, they may be having a true pulmonary issue, but to have ILD is quite unusual. And again, I think that that's supported by the fact that I just don't see these patients in practice. And so this is not a common manifestation of disease for them. And Dr. Hallowell, you can comment if you have many patients with IBM.
No, I don't have any. I mean, it's been reported, so it would be case reportable, as I think you had said earlier on in the session. So it doesn't mean it can't happen or doesn't exist, or they might have an overlap myositis syndrome, right? They may have, concurrent features, and so it's certainly possible. But again, without knowing the details of the case. But no, I don't have any IBM patients. So.
Okay, our last question is, what advice do you have for myositis patients to improve or live a better quality of life?
Well, I think I would say exercise as much as you're able to, as much as your body will allow you to. Surround yourself only with people that you love and who love you, and laugh more. As cheesy as that sounds, because there's no, Dr. Johnson had already stated there's no, you can go online and find magic soup that's $3,000 a month that is claiming to cure fibrosis. You can find magic herbal supplements that are supposed to increase your oxygenation. You can find all kinds of stuff out there. If there was any real evidence or any inkling that it helped at all, I guarantee you we would have heard about it. But there's no known dietary changes, anti-ILD diets, anti-inflammatory diets, or anything that has helped or been proven to help. But we know that stress is bad for you. We know that sleep is good for you. We know that laughter is good for you. And people live longer when they're happier and surrounded by people who care about them. And so the whole purpose of all of this, and I think the reason we are here and the reason all the participants are here, is because we all just want to not necessarily even live longer, but live better. And a lot of that is just trying to make the most of the little things. And so that's what I would
Thank
prescribe.
you. Do you have anything to add, Dr. Johnson?
No, I would just enthusiastically support that. I agree.
Well, thank you both so much for being here today. We really appreciate the critical work you do in the community and for our patients. And our Q&A has had several statements to that effect, thanking you for your service. And so we really appreciate you being here today.
Pleasure. Thanks for having us.
All right. Let me go in. I have a couple of things to tell the audience before we get out of here. Our next Ask the Doc is going to be September 15th at 6 p.m. Eastern, and it will be with physiatrist Dr. Tai Wong Chung. And again, that's September 15th from 6 p.m. to 7 p.m. Eastern time. And then we also invite you to participate in our 2022 International Annual Patient Conference, which will be held in Orlando in September next month. It's in person, but also there is a virtual offering of 2 days, the Friday and Saturday. So if you cannot travel, you can still participate. You can go to our website at myositis.org to register. So thank you very much. For TMA, I'm Rachel Bromley. Good night.